Welcome back to The Center. This is a podcast from the Center for Neurotechnology and Neurorecovery at Massachusetts General Hospital. I'm your host, Josephine Bouclez. Today we're going to be looking at two diseases that may seem very different on the surface, but share striking similarities in the way they affect and are affected by sleep. Dr. Alice Lam and Dr. Alex Bender are going to discuss how research into Alzheimer's disease and epilepsy is helping us understand why sleep matters and how neurotechnology is changing the way we study it. Dr. Lam directs the Lam Lab in the Center for Neurotechnology and Neurorecovery. She completed her residency and fellowship training in epilepsy and clinical neurophysiology at Massachusetts General Hospital. She's currently an associate professor of neurology at Harvard Medical School. Dr. Lam's research explores the interface between epilepsy, neurodegenerative diseases, sleep, and cognition. As a physician, she takes care of patients in both the epilepsy clinic and the memory disorders unit. Dr. Alex Bender is a physician scientist and epileptologist at Massachusetts General Hospital. He also completed residency training in neurology and a fellowship in epilepsy at Massachusetts General Hospital. Dr. Bender's research focuses on understanding the neurophysiological mechanisms of sleep dysfunction and cognitive impairment in adult epilepsy. His research combines innovative digital cognitive testing with advanced electrophysiological analysis of brain activity. He's the recipient of the NIH-NINDS K23 and the Mass General Neuroscience Transformative Scholars Award. As a physician, Dr. Bender works as an epileptologist in the Division of Clinical Neurophysiology. Dr. Lam and Dr. Bender, welcome to the Center.
Thanks for having us.
So, Dr. Bender, I want to start by asking, what is the role for sleep in our general health?
Sure. It's a big topic, but I guess I'll just start, with the simple and most obvious, explanation that sleep really is a biological necessity. It's vital to all elements of our health. And that's probably most obvious for most of us when we don't get enough of it. So, I think we've all had the experience where we have a night or multiple nights of poor sleep and we're feeling the effects of that afterwards. But that can mean that, it's affecting our judgment, it's clouding our thinking. It may affect our memory and our attention, and we're more likely to make errors or mistakes when we don't have good sleep. So I think that's probably the most obvious and explanation, and perhaps to not be understated, just to point out how important it is for all of us. And for most people, that may be limited to a few times when we stayed up too late cramming for an exam, for example. But sleep disorder is actually extremely common, and I think in this country, about 1 in 3 people report not getting enough sleep, and sleep disorders are a common problem not only in themselves as their own entity, but as also comorbidities from other medical conditions or neurological conditions, and I think we'll talk about some of those today.
Definitely, and I think we have learned over time that sleep is important for memory consolidation, and you both study memory disorders and epilepsy. So Dr. Lam, can you talk a little bit about what the link is between these diseases, specifically Alzheimer's disease and epilepsy?
So as you had mentioned earlier in the podcast, Alzheimer's disease and epilepsy are pretty closely linked. There's a bidirectional relationship actually between them. So if you have Alzheimer's disease, you have about a 2 to 3-fold increased risk of developing epilepsy. And if you're someone who has epilepsy, you have a 2 to 3-fold increased risk of developing Alzheimer's disease. And people are still trying to understand how those relationships exist. Why is it that epilepsy might predispose to Alzheimer's and vice versa? But I think that's an area of fairly active research currently.
And why are those disorders similar with regard to sleep?
How they're similar with regard to sleep. So, they're both disorders that affect sleep, for sure. So even in Alzheimer's disease, impairments in sleep or disruptions to sleep are one of the earliest signs, where people have noted impaired sleep, even years before they come in saying, my memory has gotten worse over time. With epilepsy, similarly is associated with other kinds of sleep disorders. Things like sleep disordered breathing, for example, are very common in people with epilepsy. I guess I would say there's probably likely bidirectional relationships for both of those diseases as well. So, I mean, what I mean by that is sleep can affect, Alzheimer's disease. Alzheimer's disease causes people to have, disruptions to their sleep, but sleep disruptions can make the symptoms and possibly even the progression of Alzheimer's disease worse as well. And similarly in epilepsy, we think that epilepsy is associated with, again, abnormalities in sleep, but at the same time, abnormalities in sleep can, make epilepsy harder to control in some patients. So I think there's a lot of different relationships like that we could talk about, and I'm talking about them kind of at like a high level thing, but definitely when you look at it both in terms of like amount of sleep, right, like quality of sleep, all the way down to like the nitty gritty of like what your brain waves look like during sleep in these diseases. When we've explored a lot of these things in some of the work that we've done, we do see differences kind of like at many different levels.
I think that gets into, how we think about studying sleep and whether we're studying it at like a macro level and thinking about, things like sleep duration or sleep quality, all the way down to, studying, brain activity and sleep and sleep microarchitecture.
Yeah, those are all really important points, but I do want to take a step back before we kind of dig into them a little bit more and have you, Dr. Benner, just define Alzheimer's disease and epilepsy for us.
Well, I mean, those are both, neurological diagnoses that refer to, two entities that, really are defined primarily clinically. So, just to start off with epilepsy, epilepsy really is a disorder of recurrent seizures, or the propensity to have recurrent seizures. And there's different ways to kind of come about that diagnosis, but one of the most common ways that someone might be diagnosed with epilepsy is they've had 2 unprovoked seizures. Then that would meet criteria for diagnosis of epilepsy. So the term epilepsy really just refers to the likelihood of having recurrent seizures.
And just to be clear, for people who may not know what is a seizure, right? So the way I explain to patients is like a seizure, think of it like an electrical storm that's happening in the brain, right? And that storm can be happening in one part of the brain, right? Or it could be happening all over the brain all at once. And really your brain cells, they communicate with each other through electricity, essentially. So when you have like a disruption in that electrical activity, when you have a storm like that, it can affect your function in different ways depending on where that electrical storm is happening. Just to be clear.
Yeah. And that's like, I think that is, what we're talking about is really the clinical diagnosis, but I think for us seeing patients with epilepsy and for patients who have epilepsy, there's a lot more to it than just seizures. And, I think epilepsy affects many other aspects of our health and our life. And patients will tell you, when you talk to them in clinic that, it's not just the seizures that are the problem. It's that, their memory is not as good, or their mood is terrible, or, other aspects of kind of different elements that affect quality of life, can be impacted with epilepsy. So there's really a lot more to it than just seizures, but the clinical diagnosis is made based off of the presence of seizures. So that's how we diagnose epilepsy. Alzheimer's disease refers to a different entity, which really has 2 parts. One is it refers to the presence of a neurodegenerative process in the brain, and we think that that's linked to the accumulation of both beta amyloid plaques and tangles, and these are basically 2 of the pathological hallmarks that you might see if you study the brain under a microscope. So we think that that's the neuropathological entity that leads to the neurodegenerative process, and then but that's not enough. And then you also have to have the clinical syndrome, which refers to really a pattern of decline in terms of your cognition and memory over a period of time that could be observed. So when you have both of those, I think that that's really kind of what leads a clinician like Dr. Lam, who sees patients in the memory clinic, to come to a diagnosis of Alzheimer's disease. I don't know if that's a good summary from your standpoint, but
Yeah, no, that's a great summary. And I'll say it is a disease where the definition is still kind of
It's
continually
kind of
being
evolving, yeah.
refined as we have better ways of studying the brain in living people. 10 years ago, 15 years ago, we would tell people you can't be diagnosed with Alzheimer's disease until after you've passed away because, there's no way we can like look at what's in your brain to see if you're actually building up amyloid plaques or these tau tangles. But really, in the more recent years, we have different kinds of studies that allow us to detect these proteins or detect abnormal buildup of these proteins, either looking at your spinal fluid through a spinal tap or looking, we have no imaging studies that allow us to detect buildup of amyloid plaques and tau tangles in the brain. And even now, blood tests they're not really in widespread clinical use yet, but the data for blood tests to diagnose Alzheimer's disease is looking quite promising. So with kind of the availability of these biomarkers now, we're able to hone in a little bit more in terms of making sure people have the correct clinical picture, but also like the correct pathology that goes along with that clinical picture to diagnose Alzheimer's.
Yeah, so it's interesting that you have kind of bridged the gap between these two diseases, one being described as this electrical storm, whereas the other is this accumulation of these beta amyloid plaques and neurofibrillary tangles that kind of come together on this link of memory, and specifically within the temporal lobe. And I think that was something that was really interesting to me, was the central involvement of the temporal lobe in both diseases. And I was wondering if, Dr. Lam, you could talk a little bit about the role of the temporal lobe and how the hippocampus kind of plays a central role in both disease states.
Yeah. So the temporal lobe, everyone has two temporal lobes. Well, not everyone may not have two temporal lobes, but typically a brain has two temporal lobes, one on each side. And the temporal lobe plays an important role in multiple things. Memory is one of the big things that we think about. Emotion, our ability, olfaction, things like that. But it is a central part to both epilepsy and Alzheimer's disease. So with regards to epilepsy, the most common type of, like when we say focal epilepsy, meaning epilepsy seizures that start in just one part of the brain, the most common type of focal epilepsy is temporal lobe epilepsy. So it just happens to be a very common place where seizures can start. And then in Alzheimer's disease, we know that the temporal lobe is one of the areas of the brain where some of this pathology that we've talked about first begins to accumulate, right? And so the hippocampus in particular is vulnerable to this kind of pathology. The hippocampus and the mesial temporal lobe, which is the hippocampus and some of the areas adjacent to it, is particularly vulnerable. And so that was one of the things, this kind of anatomic overlap between these diseases that kind of made people think about, like, well, if the hippocampus is really affected in Alzheimer's disease early on, but we also know that the hippocampus is one of the most common places that seizures arise from, then, how, maybe that's one of the ways that Alzheimer's disease can lead to epilepsy, right? So that was one of the things that kind of support that link between the two diseases.
Dr. Benner, could you talk a little bit more about how sleep changes in patients with Alzheimer's disease?
Sure. Yeah, and I think maybe just to add a little bit of comment too to the prior question. I think as we're talking more about memory consolidation and kind of these other aspects of what happens in the temporal lobe and how that's affected in sleep, I think it's important to remember that that sleep is not just a passive process. It's not just a period of rest. Really what's happening in sleep is quite active, and there's a lot going on in the brain during sleep. So, I think all of the things we're talking about are things that reflect active processes that may be working properly or not working normally in sleep. But with regard to your question on the duration, so that varies quite a bit from patient to patient. I think there's actually probably a lot of similarity between epilepsy and Alzheimer's disease in terms of that topic. So on the one hand, we know as we get older, we don't sleep as much. But beyond that, sleep can be affected even more in Alzheimer's disease or in epilepsy through different ways. So one might be we have trouble falling asleep, or we have trouble staying asleep for the whole night. And so that can lead to fragmentation of a normal night of sleep. And that's going to affect sleep quality overall and how someone's functioning the next day. But that can occur in both epilepsy and Alzheimer's disease. And so I think it's not just the duration per se. It's not just that someone maybe only slept for 6 hours in the night. It's kind of how that sleep was over those 6 hours, and did they stay asleep the whole time, or were they waking up a lot? And I think that there's been studies showing kind of both of those things exist in Alzheimer's disease and in epilepsy.
Yeah, that's really interesting. And how do you quantify sleep quality and duration through various biomarkers?
So sleep, so good. Yeah, I think the quantification of sleep, has many different levels. So on the like macro scale, or what we might refer to as sleep macro architecture, there are several different ways that we might think about measuring sleep. So one is duration, which you asked about. Another one is how long does it take to fall asleep? So how much time does it take for you to fall asleep when you're trying to go to sleep? Another is then over the course of the night, do you stay asleep or do you wake up frequently? So that refers to like how often are you having arousals or awakenings at night that that might not be within the range of what the average person has. And then in addition to that, we can quantify things like sleep fragmentation or sleep efficiency. And both of those things are related. They essentially refer to over the course of a given night, how much time do you spend asleep versus how much of your sleep is interrupted by these different arousals or awakenings. And then the last part of kind of sleep macro architecture is how much time we might spend in each stage of sleep. So sleep can be divided generally into what we call non-REM sleep and REM sleep. And there are actually multiple stages within those two categories, from stage 1 of non-REM sleep to stage 3, and then REM sleep. And we can quantify how much someone spends in each of those various stages. So those are, I think, kind of the main ways that we might think about quantifying sleep macro architecture. But there's been a lot of interest over the past decade or so in actually looking more into the brain activity in sleep. And that really refers to what we call the sleep microarchitecture. So things that you can't really measure with just a standard sleep study per se, but things that you actually need to be recording, like brain activity, to measure. And so when we think about sleep microarchitecture, we're quantifying physiological brain signals that we're recording overnight, things like spindles or slow waves. And these are things that are characteristic features that we might see on the EEG, but a patient, wouldn't know whether, what's happening, when we're recording that activity.
Brenner, could you discuss how Alzheimer's disease and epilepsy are similar with regard to their sleep microarchitecture?
Yeah, sure. So that's something that we've studied a little bit. I think we're still learning about that. We started looking at the sleep microarchitecture in epilepsy. I started in epilepsy, and then we kind of started translated that to Alzheimer's disease. But part of our motivation in doing that was because that certain elements of the sleep microarchitecture are known to be central to memory consolidation in sleep. All right. And I think, part of our goal in studying sleep in these disorders is not just to just understand what changes in sleep, but to understand, well, how can this inform how we think about cognitive impairment and the mechanisms that lead to cognitive impairment in these disorders, and how these things might affect their quality of life. So that was part of our motivation in focusing in on that. But what we found was really interesting. In epilepsy, we found that spindles in particular, but also to some extent some of these other features were really impacted and reduced beyond like the level you would expect, in a control population. So there was a reduction in the amount of like spindle activity, for example. But what was interesting is that this finding wasn't just uniform across the whole brain. We noticed that this was really specific to certain brain regions, and it was most prominent in the temporal lobes, which we've talked about a bit already, but also extending into kind of the frontal regions, and sort of this like frontal to temporal network is really a network that we know can become dysfunctional in certain types of epilepsy, especially the temporal lobe type of epilepsy that we've studied. And so, I think that finding in itself was pretty interesting, but what we found in our initial studies was that itself was also correlated to what their cognitive performance was on like standard neuropsychological tests. Now, there's a lot more to do in that domain. I don't think we have a full understanding of that relationship. But I think it got us thinking more about this and wanting to learn more. So more recently, we've started to look at this in Alzheimer's disease or in an Alzheimer's disease population, and we're starting to see similar things. But the interesting things that are different have to do with kind of where these changes occur, instead of being located more in the kind of the frontal and temporal regions, maybe it's more in the temporal or posterior temporal regions. And we think that may have something to do with how kind of the pathological changes are happening in Alzheimer's disease. But again, I think that's, these are things that we're still kind of actively researching.
So you mentioned some sleep stages. Could you clarify what the importance of these sleep stages is physiologically?
That's a good question. I may not be able to give you a good answer on that. I think that the sleep stages have they're defined by what we see primarily on the EEG. So what we see in the brain activity, with the exception of certain kind of other elements that would help us support kind of making those distinctions, like how much muscle activity you have, for example.
Respiration rate.
Yeah. And so I think we can define these different stages of sleep, and there's a known pattern for how we progress through them throughout the night, how much time we spend in them, and what sorts of things might go wrong in each different stage of sleep, right? But I think it's a little bit harder to answer like what the biological or evolutionarily preserved role is for each of these stages. But I will say that there has been more research into understanding like what are the important processes that happen in each of these stages. And I think that's one of the areas that we're interested in. And memory consolidation is definitely one of those, but it's not the only one. So that's maybe not the best answer, but I think that these are things that are still kind of being studied and understood.
Yeah, so kind of a follow-up to that, is there a sleep stage within which memory consolidation is confined?
So sort of, but not entirely. Most of the research into memory consolidation has focused on stage 2 and 3 non-REM sleep, which is when we see things like spindles or slow wave activity. And so a lot of the research has been focused on that, and that's certainly an important part of sleep that's involved in memory consolidation, if not the most important. But I think that it's certainly the area that's been studied the most. However, REM sleep probably plays an important role as well. That's not something that we've studied in the lab, but others have, and that probably also plays an important role. So, and I think as we learn more about how memory consolidation plays out throughout each of these various stages, there may be surprises. We may learn things that really extend our understanding of it. But currently, it's the stage 2 and 3 of non-REM sleep and REM sleep.
Yeah, so it's kind of a follow-up to the sleep staging discussion. In 2020, Dr. Lam, your lab developed a sleep stager that you've been using frequently in research. Can you talk a little bit about the sleep stager, its development process, and how its applications differ from the traditional sleep staging processes?
Sure. So this was work that we did in collaboration with Brandon Westover's group. So the idea is, so usually when patients come into the sleep lab for a sleep study, they get recorded, they sleep overnight, and then there's actually sleep technicians, basically, who actually look through the recording visually. They review every second of the recording, essentially, and they're manually deciding, every 30 seconds what stage of sleep someone's in. So that's a pretty burdensome process, I would say, right? It just takes a lot of time to go through data like that. And so, certainly, much before I started working on that area, many people have been working on that area to say, like, can we teach computers how to stage sleep, essentially, right? Can we develop an automated way of staging sleep that would be as good as, human sleep stagers, essentially? So Brandon Westover's group has been, this is something that they've continued to work on and refine, but they had a very large data set of sleep recordings taken from patients who had come to Mass General. So we had their sleep recordings, and we had their sleep stages that the sleep technicians had manually scored, and that was kind of the gold standard, right? And they had created an algorithm based on the EEG signal, the brainwave signal from these sleep recordings, that basically worked as well as the performance of this algorithm was as good as human sleep stagers. That's great for these kinds of sleep studies. We were interested in using automated sleep staging because for the kind of research that Alex and I do, we're looking at large amounts of EEG data, right? And we're interested in kind of extracting parts of the EEG. We only want to look at, maybe asleep portions of the EEG, right? And so having an automated way to stage sleep is a really nice way to be able to get through like thousands of hours of recordings without having to manually annotate these things, right? And so the issue with using the kinds of algorithms that Brandon's group had developed was they had developed these algorithms specific to sleep studies, which are recorded very similarly to EEG studies that we use in epilepsy, but there's sort of a technical issue in terms of what we call the reference electrode and how the electrodes are set up that made it such that we wouldn't easily be able to apply their algorithm to EEG data that's collected in epilepsy patients or Alzheimer's patients. So we basically worked together and sort of essentially tweaked Brandon's sleep staging algorithm so that we could use it in EEG studies rather than just sleep studies, and that we could use it in any kind of EEG that was recorded under kind of like a standard. There's a sort of an international standard for what channels people use. And so as long as people were using those channels, it could be used for any kind of EEG recording like that.
Could you clarify what you mean by channels?
Yeah, so if you've ever seen an EEG study, basically what an EEG study is it's a recording of brainwave activity, okay? And the way we record it is we have these different electrode contacts or channels, essentially. Mm-hmm. And there's like a metal disc, okay, and a wire that goes to a recording device. And we place these wires basically across the scalp in a very standardized way so that we're capturing brain activity from across the scalp. So each of those wires records some, a specific part of the brain. So you could call that an electrode or, an electrode contact or a channel, same thing, but we're just talking about recording of electrical activity from part of the brain.
Are you looking to use the data generated from your sleep stager to diagnose Alzheimer's and epilepsy?
No, I wouldn't necessarily say the algorithm is making the diagnosis, but I think it's really facilitating a lot of the research that we do, trying to understand sleep in these disorders, again, allowing us to really go through large amounts of EEG data from many, many patients and kind of just extract the areas of EEG, where someone's asleep in a specific sleep stage that we're interested in. And maybe, Alex, you can talk about, some of the different ways that you've used that in your own research.
Yeah, I mean, it's been a really powerful tool, I think, for us. And, a lot of it has to do with just the flexibility that's allowed us to rapidly kind of study new data sets, with hundreds or thousands of hours, of overnight EEG. And anytime we're doing that, the first steps, in being able to do a particular analysis to answer a question is to set up the data in a way that we can actually use it. And so after some initial kind of processing steps to get the EEG data ready, the next, like most immediate thing we have to do is figure out when the patient's asleep and when they're awake. And then when they're asleep, we have to figure out what stages of sleep they're in, because certain things that we're interested in studying occur during very specific stages of sleep. So for example, I mentioned spindles earlier on, and we know spindles occur primarily during stage 2 and 3 of non-REM sleep. And so we need to be able to identify all of those parts of the EEG and sort of have that annotated so that when we run, particular analysis, we're looking at the right parts of the EEG. And so instead of having to train and hire a sleep technician to do this for every next EEG that we acquire, which would take many hours, out of the day trying to do that, and honestly would be quite expensive. We're able to run it through this algorithm that's already been validated, and apply that to a new data set. And so we've been using it, really in kind of all of our studies, over the last, at least since I've been in the lab. Yeah.
So both of you have really emphasized the importance of having a standard EEG data collection protocol. And I think there's a lot of excitement around remote EEG recordings, specifically tracking your sleep through these EEG detecting headsets. And I'm just curious if you see a future where you will be prescribing patients EEG headsets to take home to monitor their sleep waves.
I can answer first.
Go ahead. Yeah.
So I guess, first, I think there's a lot of potential there for sure. And I know that there are companies that are developing remote EEGs or have already developed them that can be essentially self-applied, by a person who has it. In a sense, a lot of the EEGs we are doing or using in our studies are remote, meaning that they were set up and and the participant then goes home and has the EEG on overnight at home or during the day. And then at some future point in time, the EEG is taken off. So in that sense, I think, even with our current standard of applying like a full scalp EEG, we're doing that in ways where it's essentially done remotely once it's set up. And I think that's been really useful, I think, for us, because part of our interest in doing these studies is understanding how someone's sleeping in their home environment or, under normal circumstances, not just like in the hospital per se. So that allows us to do that, and we're already doing that. But I think what you're referring to is not just the ability to kind of do it remotely, but, the ability to do it like unsupervised or without, trained EEG technicians setting it up. And some of those setups and devices, I think are really exciting. I think the difference is not all of those setups are going to include all of the EEG electrodes we would normally use in a standard EEG, and typically they're not applied with the same quality in terms of how they're attached to the skin, and so that can affect the quality of the recording you get. And I think that for a lot of the analyses that we're doing, at least at the current time, it's really important to us to make sure that the quality of the recording is really high. Because even small amounts of artifact can affect, what you're seeing and what the output of your analysis is. So I think one of the avenues of sort of addressing that gap is to start to utilize some of these remote devices in conjunction with kind of standard setups and really kind of work through where the differences are and how to kind of improve upon them so that we know that when we do something like that we're getting like a good quality like recording.
Yeah, I would agree with that, and I'd say I think the use of remote monitoring has obviously a lot of appeal, right, in terms of the ease of use and the convenience, and it's really just I think it boils down to what questions are you trying to answer, right, with the technology. And so if you're just trying to say, like, I just want to see how much sleep someone's getting, right, then a simpler device like that might be very usable. And even you're talking about EEG headsets, but for monitoring sleep, people will often use actigraphy, right? These are kind of wrist monitors that kind of gauge kind of like how much activity someone is, how much physical activity basically someone is is doing, and that's even easier in some ways than wearing something on your head to measure sleep, right? So for things like that, how much sleep is someone getting? Maybe even how disrupted is their sleep, things like that. I think those monitors would be really good. For more, as Alex said, for more kind of intricate things where you're interested in like sleep spindles, right, or other kinds of microarchitectural features or things like that. It's not that I don't think they could do it, right? I think you're absolutely right that we'd have to have a better understanding of like the quality of each different device and its its recording characteristics, right? Like the signal that's actually captured with the device. But for being able to study things at scale, it would be nice to just mail people, right, like a device, and they just wear it for a while, and then you get the data. But
probably soon enough.
Might be, yeah. Yeah.
So, Dr. Lam, you're leading the ELUCID study, which is an NIH-funded multi-center prospective longitudinal study that is focused on late-onset unexplained epilepsy as a risk factor for dementia. Could you talk a little bit about this study and how interested patients can get involved?
Yeah, I'm glad you brought that up. So, ELUCID is a study of people with what we call late-onset unexplained epilepsy. So these are people who have, developed their first seizure after age 55, and basically doctors aren't sure why they had a seizure, why they developed epilepsy, meaning that like their brain MRI didn't show, a stroke or a tumor or things like that we know would otherwise cause epilepsy. And so this study really kind of gets at, one of the questions in terms of like the direct, the intersection between epilepsy and Alzheimer's disease or epilepsy and dementia, where we know these patients who present with late onset unexplained epilepsy are at increased risk of developing dementia down the line. But we don't really understand why that is, and we don't understand which of these patients, how do we predict the risk of developing, dementia or other kinds of poor outcomes that we know these patients have over time. And so this is a study where, it's actually going on across the U.S. at 7 different sites, but we're enrolling people who have, developed late onset unexplained epilepsy within the last 3 years. And then we do a pretty comprehensive like baseline assessment that involves just like a clinical history, a research brain MRI, an overnight scalp EEG to capture sleep, and then blood work to look at different kinds of biomarkers in the blood. And then we follow these people over time. Every year they come back for cognitive testing, right? So we can see how their thinking is either changing or staying stable over time. And then the goal is to, use all this data that we've collected to be able to understand, what are the factors that increase risk of someone with late onset unexplained epilepsy to go on to develop dementia. So what are the risk factors? And then, how can we predict, who's at risk? And, the idea being that if we can predict who's at high risk, then, that kind of sets us up potentially for clinical trials down the line where we can say, okay, this is a high-risk group of patients with epilepsy. We're worried that they're going to develop dementia down the line. And now we can start to look at different therapies to prevent this kind of outcome over time. So trying to understand, again, how epilepsy late in life might lead to dementia and the mechanisms by which that occurs.
Okay, so my final question is, what are you most excited for in the field of neurotechnology? And Dr. Lam, we can start with you.
Can we not start with me? I guess a lot of things to be excited. There's a lot of things, and it depends on also how you define neurotechnology, right? Because broadly, it's such a broad, broad field. Yeah. But why don't you go first, Alex?
I mean, I think I'll answer generally first. I think that the field of neurotechnology, I think, is exciting in itself because what you're really talking about are things that can be translated to help patients. And that maybe is a tool or a device or some new computer algorithm, but, that's really kind of what we're talking about. And I think in the types of research that I've sort of started on, I think the things that, I'm really excited about seeing through would be number one, are there ways that we can develop algorithms that help us analyze changes in sleep that might inform or help prognosticate, how someone might do who has epilepsy, but how they're going to do, 5 years from now or 10 years from now. Like, can we use that type of information to actually help us, in the clinic? And I think the other piece of that is one thing that, we didn't talk about a lot, but I think there are some other kind of interesting digital ways that we can assess, our thinking and our memory, and thinking about a way to kind of use those tools in conjunction with, what we're understanding in kind of sleep physiology, to help identify cognitive problems earlier, or to help treat them better or monitor them. And I think both of those, areas are areas of research that I could totally envision kind of coming forward to the clinic, in the not too distant future, because the technology, I think, is there. It's just a matter of understanding like how we can use it.
Okay, now that I've had time to think
go
about
ahead. Yeah.
I agree with all the things you said, and as I said, and I agree that there's just a lot of exciting areas in the field. If I'll highlight one, I'll say I think the use of neurotechnology to do things that humans can't do is something that's pretty interesting to me. And so there's different examples of that. I'll use like an imaging example first. So, when someone comes in with a neurological disease, let's just say epilepsy, for instance, there's a lot of people who come in and we say, okay, let's get an MRI of your brain. Let's see what your brain structure looks like. Let's see if there's something in your brain that might be causing these seizures, right? And a lot of times people end up with a normal brain MRI and, we can't see anything. But, when we're reviewing an MRI visually, you've done this too, Alex, right? It's a pretty it's pretty crude from the standpoint of, we're visually looking at the scans, but it's impossible to look at every single detail. I mean, the radiologists, of course, are trained to do this kind of thing, but there are things that even the radiologists miss, right? And so there are people who are developing interesting computer algorithms that can look at brain MRIs and identify things or identify areas of abnormality using quantitative approaches, right? That would be very difficult for, even a trained human to easily pick out, right? And so kind of assisting and helping, helping see things that we can't actually see easily. So that's like an imaging example. And then with EEG, kind of a comparable thing, and we've worked on some algorithms that do this, but we talked about scalp EEG, where we're recording brain activity on the surface of the brain, and that actually misses a lot of activity that's going on deeper in the brain. A lot of activity. We talked about the hippocampus, one of the areas of the brain that is most prone to developing epilepsy. Well, it turns out you can't actually see hippocampal electrical activity on scalp EEG, right? So we've worked on developing algorithms to try to infer what's going on in the hippocampus using surface recordings, right? And again, being able to see something that most trained human EEG readers wouldn't be able to see or detect clinically. So I think that, those are ways that we can kind of improve our diagnostics, right? And get patients the help they need, or make, either diagnose them more quickly or have a better understanding of what's actually causing their neurological disorders, in using technology in this way.
That's all very exciting stuff. Well, thank you again for both joining me for this interview today and continuing this incredible body of research. I'm very lucky that you both joined me today on the center.
Thank you for having us.
Thanks so much for having us. Yeah, this was fun.